Okay, so I will just share the video and then we will take one slide at a time. Okay. Yeah, this is what I was, this was the first slide in the video that I had sent. And if there are any questions on any of the slides, you can just stop me and we can discuss that. So history is explicitly clear. I think this is one of the most important slides of the entire lecture. Rest of all the things follow what
ಆಯ್ತಾ
yeah, I think you will have to
10% ಇದೆ ಮೊಬೈಲ್
Aval,
Yes,
you will, since you are the host, you will have to mute if there is a voice coming over from anybody, because I have been out of this, so you will have to mute Dr. Hari Kumar.
ಸರಿ
okay, sir. Let me check.
Yeah, so okay, so the first slide is about yeah. So if you have any questions on this, you can ask, because this is the principal slide. Basically, we have to do all this. I've described in my video why we need to do all this. And out of this whole gamut of tests, obviously these first 4 are the most important ones, and the rest 4 ones are also important. Apart from this, if you're planning to prescribe atropine, you should always check for accommodative lag if it is there or not. Pupil size, again, if you're going to give atropine, you have to check all these, because if they get affected, you need to have a baseline. Before you start atropine, you need to record certain parameters to know whether these things have got affected or not. Shermer test is not really mandatory, but since you are going to put drops for a very long time, it is a good idea to record that. Vitamin D, serum vitamin D, I'm not really a big fan of, talking about that vitamin D really affects myopia. Nevertheless, if there is a deficiency, it is a good idea to replenish that deficiency. Any question, Dr. Harikumar? Okay. So topography, I normally try to do topography in almost all the patients because I feel that we should not be missing out on even subtle lesions. Aberrometry, not really routinely. Choroidal thickness, if you have the machine, you should go ahead and do it. And OCT macula, I do it, but it's not really mandatory to for a myopia clinic or a myopia therapy to start this. So if there are no questions on this, I will move on to the next slide.
Sir, I have few questions.
Yes, go ahead.
Sir, the first is for cycloplegic refraction, cyclopentolate or hometropine?
We use hometropine as a principle. Yes, we have been using cyclopentolate, and it happens at least once in a year, that you will get some patient of psychosis, or there will be some disturbed this thing. Also with cyclopentolate, you have to stop yourself from using it in developmentally delayed kids and pediatric neuroophthalmic patients. So if you have to stop yourself from doing it, it is not, there is no literature which suggests that cyclopentolate is better than hometropine or hometropine is better than cyclopentolate. Just that cyclopentolate is more of a Western country, more of a US thing. So it is more in the market. Not that hometropine is not a good drug. RP Center uses hometropine. The place from where I got trained, Arvind Eye Hospital, Madurai, uses cyclopentolate. So I think it is, there is no, truly not really a, really a botheration whether you are using cyclopentolate or hometropine. Just that in my private practice, I feel that, as a single owner, single practitioner, if something goes wrong, it becomes very difficult to tell the patient what is to be done. So I think a week back, I had a call from a pediatric ophthalmologist from Indore saying that, she had put cyclopentolate and the child is behaving, he's behaving like a very strange way. So what is to be done? So I told her that, you can give the kid some sedatives, give him a lot of fluid, so that, there is washout or something like that. But I have never heard hometropine doing all this. So I would like to play safe. The effect is same. Hometropin is almost as good as cyclopentolate. There is no real choice that cyclopentolate has a better cycloplegic effect.
Okay, thank you, sir. And sir, another question is, if we are using home atropine, then after how many days PMT should be done?
So normally what happens is that we have stopped the point of PMT because patients don't come back. But it is a good idea to do it after 24 hours. Sometimes you have to wait for 2 days also. So it is variable with patients. But what we do is when the patient comes or walks into the clinic, we would do the refraction, try to do some dynamic retinoscopy, try to see their subjective refraction, and then put hometropin. But if there are cases where you have thought of something and post hometropin your refraction is coming even less, then you have to call the patient for PMT. So typically we will call them after 24 hours and we'll try to see whether the accommodation has gone or not. But I think in private practice, what happens is that it is a lot depends on when patient wants to come. But at least 24 hours, definitely.
Thank you, sir.
So this is something which we follow. This is the basic myopia control sheet which we follow. Earlier we used to take only axial length and spherical equivalent data, but now we have also started putting in axial length upon CR ratio. So I think what happens is as the time goes on, your myopia sheet also changes. So right now we have designed our own medical record software because the medical record which we were using was very bulky, lot of data, and the problem was that we didn't really want that data for this particular myopic patient. So for purely for myopia control, we have designed a simple data which has only 25-30 things, and that serves our purpose because mainly it is so we have designed it mainly for research purpose so that we can know what we are doing and we can improve it because all of us and I would congratulate all of you that you have shown some interest in myopia, and myopia is currently something which will become a real thing after 10 years, and people would really look back and feel that these are the guidelines which the 10 years back the previous generation could do because they could find out the data, because they could really put the data into place to find out what is going on. So what has happened is that at this point of time, not everything that I would be doing will not get changed. So maybe after a couple of years, I may add few more things and I may completely lay off some of the things which currently I feel should be done. So that's how right now the understanding of myopia is changing. So at this point of time, whatever comes, we can have an open mind, think about it, and if logically it fits into our system, then we can do it. And if there are no problems, there is no we don't expect any backfiring, we can do those things and gradually again see whether they are really working for us or not. If they are not really working for us, then we can move further from that. So that was regarding the myopia sheet. This is something which came up, I think around 6 months or 8 months back or 1 year back, that axial length upon CR ratio is more important than purely axial length. The reason is pretty simple that once you have see, whenever you try to predict something or whenever you try to see the variance, whether so the point of variance is that whenever you have a set of patients like you have myopia, so not all myopic patients will be axial, not all myopic patients will be truly into a particular set of criteria. So what you do is you take axial length, you take corneal curvature, and now you have got two variables. So what you do is, and why these two variables are important, because the corneal curvature can contribute to myopia, and it is the most strongest refracting surface, and axial length is the actual length where the image is going to form. So these two parameters become very, very important. And that is the reason why axial length upon CR ratio has become, not a gold standard, but at this point of time, it can easily explain how myopia is distributed, So right now, axial length upon CR ratio is being done to understand and to agree upon the fact that anybody who has AL upon CR ratio more than 3 would be a myope. But the point to understand here is that not necessarily that will be a progressive myope. So right now we are not sure who will progress, who will not progress. So the whole gamut, whole argument is to know quickly who will progress and who will not progress. Just like in glaucoma, you have multiple predictive softwares. In myopia also, I think we will have softwares. I think I have described two of them. But as the time goes on, more and more softwares will come. And this is what I was really talking about. See, what they have, what is the heading? The accuracy of axial length and axial length upon CR ratio for myopia assessment. So basically, what you are doing is without going for a refraction, you are trying to assess based on axial length and axial length upon corneal curvature ratio whether this patient would be myopic or whether he will not be myopic. Now, what they have found is that the prevalence of myopia as the AL upon CR ratio increases, and if it is more than 3.2, then the chance of the fact that it is myopic, the patient is myopic, is almost 98.5%. So that is what I was saying, that this can predict myopia, but may not predict myopic progression. And as all of us, we have to understand one basic thing. We only talk about myopia progression, the whole course, everything that we discuss. It is not about, reducing the myopia. It is about reducing the myopic progression. So for us, most important thing is that there has to be a progression and a documented progression. Now, this is what, this is a calculator. If there are any questions on the previous slide, I can answer. And all this, I think I am just repeating myself. All this I have, the whole purpose is that you should be aware of this. That is the reason why I record videos, so that you are aware of that and we can start from there. If I talk the same thing, it doesn't help anybody. Now, this was a video which I was trying to show. I hope you must have gone on the website and must have played with this BHVI, Branholden Myopia Vision Institute. You can see that there are multiple variables. You can go ahead and change the variables, and based on different variables, it will give you expected myopia progression. And with particular management, what management you have used, it will tell you what management you have used and how it is going to affect the myopia progression. Now, if you move further, you will also get a very important point. If you move further, you will see this. Yeah, this is a very interesting thing. Now, what it is trying to tell you is that there is a predictive score, and in that predictive score, there are few important points which they have tried to tell you, and those points are, what are those points? Those points are probability of becoming myopic within 1 to 2 years. That is 31%. In this case, it is significantly higher. The moment you change this, so it is basically, if you see, the moment you change parental myopia, it becomes moderately higher. The moment you change it to a higher hyperopic reserve, it goes to significantly lower. The moment, so it is basically the refractive error, baseline refractive error, and parental myopia. So these are the two things which tell you whether patient will become myopic or not. And your main point is, what is the baseline refractive error? Number one. Number two, whether parents are myopic or not. So we don't really have to go to that calculator to find this out, but these are the two important indicators. Even clinically, you can see what is the baseline refractive error and what is the parental myopia, and move further with that. So this also makes sure that you will know whom to call when. So that is also very, very important. Now, this was something which I think we did there was a meeting, and this came out of that meeting which happened at LVP. Now, we have to see these three things, and then you have to identify the axial myope. So you have to identify axial myope, and the second most important thing is to pick up the progressive myope. If there is no progression, nothing is there. I mean, there's nothing for us. If the patient is not progressing, we just give glasses and move further. These are the risk factors. So if there is a progression, you have to select the appropriate treatment strategy and keep calling them. And this is how you gradually come out of it. So total duration 2 years. Why 2 years? Absolutely, there is now at least there is evidence, at least by LAMP, there is good evidence that you can easily continue it for 3 years or even more. 2 years mainly because all the studies which were done prior to impact guidelines were for 2 years, and so I think they stuck with 2 years, and you have to keep following them even after stopping the treatment. You have to look for rebound with all the treatment options. Rebound is more common with atropine, more common with higher concentration of atropine, and so this is a small algorithm to know what is to be done in pre-myopes who are non-progressor. So absolutely nothing. Pre-myopes who are progressor, they may need some management strategy if they are losing out their hyperopic correction very fast. And then there are myopes who are progressors. We can either give them atropine or give them myopia control glasses, or some rare things like ortho K or red light therapy if it is available. Now this is something which came up, I think, in last 1.5 years, where now you have got new biometers, and that also tells you how much important it is at this point of time to know about myopia, because all these new biometers, they are being positioned as biometers for myopia clinic. So what they are doing is they are creating biometers mainly for myopia. Earlier, as ophthalmologists, we all know that biometers are there for cataract surgeons, but now they are creating all the biometers which are, which may not be swept source biometers. They may be basically the optical biometers, but they are creating it, putting software into it so that you can map the progression. Now, this is something which came out, I think, this year's AIUS conference. I saw this biometer. It also will do autorefractometry. So basically what they are trying to project is they are trying to create a biometer which will do your autoref and also will give you data of progression, as well as it will give you the data as to which patient will progress, which will not progress. It will give you autoref, auto-K, optical biometry, AL upon CR ratio. And in some cases, it will even give you a Placido topographer. So this is a OBM 12, which will do 12 parameter measurement. And then it will also tell you pupil size. So basically what they're trying to do is they're trying to map out and going towards myopia management. See, this is another optical biometer with myopia management software, Maya. And so it will also give you tools for assessment. So basically this is all follow-up. Patient is coming for follow-up. It is getting mapped here, and it is also giving you a topography. So this when the industry starts moving towards something, that is the first indicator that this particular branch would definitely be more and more, there will be more and more research, more and more work, both in terms of instrumentation and in terms of pharmacology, because people are now waking up towards myopia. See, such a change within 1.5 years that they have. And I think Zeiss is also planning to come up with their biometer, because they already have ILMaster 500 with them. They are also planning to go. So everybody is now gradually shifting towards them. So this is by Topcon, just for your information. This is by Remedio, and this is by Myopia Master is by Oculus. So Myopia Master is typically positioned at around 32 lakhs. OBM 12 made in India, I think it is around 15, and Maya is also around 21 lakhs. So this also gives you pupillometry. It has a Placido topographer. So all in all, point is that I think these three people are there. I think Hewitts has also come up with a optical biometer which has software for myopia. So I think more and more companies are moving towards that. That's a good thing. This, I think, we will have a separate class totally on low concentration atropine. It's a big topic. I think I have also taken around an hour to talk about it. What to do, how to follow up, everything is covered in that. Again, peripheral defocus, optical defocus lenses. I think I have covered them a lot when the lecture, I think it is chapter 4. And what should be the follow-up schedule? We have talked about it. So this is the last slide of this particular talk, but I think this summarizes everything that I have to say. The topmost part obviously is behavioral recommendation. We all know that that is the baseline. When you're not doing anything, you can definitely recommend the kids to move on for behavioral recommendations. History and risk factor, we have put down almost everything here. Maybe you can, you can take a print of this or take a screenshot of this, and you can put it in the room, so that if you have any doubts for very silly or small things, and gradually when when you keep on practicing, you would realize that you already remember most of the things that is there. So that was regarding myopia documentation and how to monitor the progress. If there are any questions, we can take. I know I'm very fast, but I practice this a lot, so it is very easy for me. You people can ask questions. I can stop sharing maybe. Yes. Yeah. I can see someone is there. Aval is there. Anshuli is asking a question. She has unmuted herself.
Yes, sir. Sir, when you convert this dioptric power K reading to radius, you do it manually. I mean, you divide it in each and every patient, or you have some software for that?
That is pretty easy. See, there is a formula comes and you can put it in the Excel sheet. And
Right.
to put it in the Excel sheet, you just have to put the number into that Excel sheet. That's
Okay.
number one.
So
Number
it
two,
is, I think,
yeah,
337.5 divided by the
example,
dioptric
one
power.
by, yes, yes, 1 by 1.33. So that is the
Okay.
refractive power, refractive index of cornea. And
Mhm.
you also, when you do your autoref, or
Mhm.
rather keratometry, it gives you R1, R2, which is radius 1 and radius 2. So
Right.
that will give you a direct reading. So
Right.
most of it, what happens is that we have gradually trained our optometrists to do this beforehand.
Okay.
So एक दो बार की बात है, then gradually they start doing it. They know
Hmm.
that you will nevertheless tell them to do it again and come back to you. So it is better to do it at the first instance.
Right.
But it
Okay.
gives you a very good indicator that this particular see, the whole thing is that if it is more than 3 or
Mm-hmm.
more than 3.2, there's a good chance that patient will be myopic.
Right.
But whether he would be progressing, that is
It
yet.
has no role in the progression, right? We can't
No, we
assess the
can't predict the
progression.
progression. No, no,
Oh,
no.
okay.
So for progression, they have got, and it will be in the next class on pre-myopia. We will talk about so there are certain indices. There is a scoring system, and I keep saying that it is very similar to glaucoma, which also in the beginning, if we remember our post graduation, we used to have Humphrey's visual field, and there used to be 4 parameters, and we used to remember what is the mean and how much it is progressing. I think that is how gradually there will be a system where we will have a risk factor, there will be an indice, and we will be putting our data into that, and we can tell that maybe this patient would progress. That is what these calculators, number one, and number two, the biometers. They all
Mm-hmm.
have a software. I think most of them have their own software to calculate who will progress and who will not progress.
Right.
So I think what will happen in future is that there will be a single machine, and that will do the autoref, auto-K, axial length, and predictive positive predictive value or predictive scoring system that this patient would progress.
Yeah. Right.
Hmm. I can see Dr. Ankita, Dr. Jaswant, Dr. Janani. Yes.
So do you check accommodative lag in all patients?
Only if I have to give them atropine. Otherwise, I will not
Okay.
check.
And you do it with the MEM retinoscopy
With
that
the mammographscopy, yes. But nowadays, I don't have to do it. They do it and write it down. I mean,
okay.
the optometrist does it and they write it down, because MEM retinoscopy is much easier once you have given glasses. So we never start atropine at the first instance. I have never started atropine on the first instance. So once the patient comes to you, we prescribe them glasses, they make glasses, come back, and then if there is a progression, then we will do the MEM retinoscopy before that. So MEM retinoscopy, for just for clarity, is monocular estimation method for retinoscopy for estimating the accommodative lag. So accommodative lag is basically when you're wearing your glasses and you are not dilated and you are looking at an accommodative target, and if there is a lag, which means that you are not accommodating as much as you should accommodate, ideally you should have a you should have a zero power. There should be neutralization because you are fixing on that particular point and you are accommodating as much as is needed. Now, if you don't accommodate, what happens is there is always a lag behind that. And if you get a minus value, that is known as accommodative lead. So which means that you are over accommodating. So typically, we felt that probably accommodative lag has something to do. We did some papers on that. Unfortunately, we could not publish it, but then we found that accommodative lag doesn't really change much with atropine 0.01%. So there is absolutely no effect on accommodative lag when we use 0.01%. So regardless whether it is more or less, it doesn't change. Even if there is accommodative lead, it doesn't change anything. Rather, if there is accommodative lag, we should not start atropine. It would increase accommodative lag. But we found that 0.01% has got absolutely no effect on accommodative lag.
Okay, sir.
Pupil
So
size
it's a-
does change, but not accommodative lag.
Okay, sir. And the first time we prescribe the glasses, usually like you call after 6 months and or you wait for 1 year to document progression.
No. I wait for 6 months only.
6 months.
And
Okay.
yeah, so we wait only for 6 months, but we call them after a month to
Okay,
see
sir.
whether the fitting is proper or not.
Okay.
And then if there is high risk patient, if we feel that the patient is progressing quickly, we may, call them earlier also, maybe at 4 months also.
Okay, sir. Thanks.
So I think there is a separate talk on atropine, but if you have, I think Dr. Prajakta has asked, so how early with respect to age we can start low concentration atropine? So normally, let's see, again, I will tell you there are two important things. One is to document progression, that is number one. Number two is to document axial progression. Atropine will work only if there is axial elongation or axial progression. So whenever we talk about progression, as a rule, in our mind, we should be talking about axial length. Because without axial length, there is no objective measurement. And in kids, it is very difficult to do atropine refraction at all settings. So what will happen is, we will be doing home atropine refraction or cycloplegic refraction. Still, there will be some amount of accommodation which is still there. We all have done it. We all know it. So if there is, so the question is, I have 2 years old patient post ROP laser who has -5 and -3.5 6 months back. Now there is a progression up to -5.5 and 4.5. Now the myopia in ROP has a completely different pathway. If so, it is mainly because of the overcrowding of anterior segment. And if you check their corneal curvature, if you check their axial length will hardly be 20.4 or 20.8. These particular patients. And what is happening here is that because the anterior chamber and the whole anterior segment is typically very small and it is sort of arrested and there is no development. Now, so what has happened is that the anterior part of the eye is there only and the posterior part of the eye may grow. Now, normally what we feel is that if the posterior part of the eye is growing by 1 millimeter, there will be a change of 2.5 to 3 diopters. Not if you have a very very curved cornea and a very anteriorly placed lens. What it is doing is, when the lens is being placed very anterior, the crowded anterior segment, what it does is it increases the effect of whatever axial length progression is there. So if the axial length progression is by 0.75 millimeters, it will increase the power by 3 diopters. Why? Because corneal curvature, if you see, I think we presented a paper also on that. If you see the corneal curvature in ROP babies, it is typically more than 46 or 47. And if you see normal babies, their corneal curvature is typically less than 44. In fact, as pediatric ophthalmologists, when we operate pediatric cataract, and if we don't have a autoref, we will put 44 because we take 44 as the normal reading for corneal curvature. So 46 and above is what you see in these ROP babies. And I don't think that, low dose atropine or low concentration atropine will work much into them, because it is the mechanism of action itself is different. So we are targeting axial elongation. If there is a documented evidence that there is axial elongation, I think then you can go for low concentration atropine.
Yes, sir. Thank you. Actually, I had one doubt. Actually, what happened? I have this ultrasound biometer. I don't have that optical biometer. And if I want to plan axial length elongation or axial length biometry in these patients, now I need some amount of sedation to check for. These are little bit uncooperative patients. So I was in doubt whether should I plan that, or should I push the things, or should I go for atropine, or should I wait? That's why I asked, because yesterday only I saw it
Yeah,
and
no, you're
asked
right.
him to come back again.
Because these patients, it is, and that is also one of the reasons. There's the question that what is the right age to start atropine. If you see all the studies, bulk of the studies will have patients above 4 years or 5 years, because it is very difficult to document axial elongation under 4 years. Because even if you say that you have documented, it's very difficult to tell a 3-year-old kid to sit even on an optical biometer.
Yes,
Because
sir. Yes, sir.
so you have to. I'm not saying that it is a cutoff, but if you can, so I will tell you, there are some patients whom we had operated for pediatric cataract, and we would take them up for examination under anesthesia, not for myopia, but even otherwise, because we have operated cataract, we want to see their pressure, we want to see their periphery, we have done PCCC, so we want to see whether everything is fine or not, and we would do their ultrasound biometry. But obviously, once they grow up, it changes. But those patients, you will have that data at 6 months, at 2 years, at 3 years. But normal, just myopic patients, it is very difficult to have good axial length data before 4.5 years of age. It is very difficult to get that. So you will have to, wait for that, because
Right. Yes, sir. Yes, sir. That will be a better option, right, sir?
yes.
I'll keep a follow-up, sir. We'll see. Yeah. Thank you, sir.
Yeah, thank you.
Hello, sir. So this is Dr. Divya.
Yes, ma'am.
Sir, actually, I am working in Varanasi right now. We have patients of 8 and 9-year-old kids who have already been using atropine for the past 3 or 4 years. So since the time they have started glasses, so since then they have been using atropine. So now they come to me asking whether to continue the drops, and if there is a rebound, what we have to do. So how to document, go with the progression later on for who have been using for the past 4 or 5 years now already.
No, so you have to see whether are they progressing actually.
Actually, they are still progressing,
Uh,
and some of them
like,
have paused. Some of them have the same power for the past 2 years. So they are not stopping atropine
yeah,
whatsoever.
so you can continue it for 4 years, 5 years also. There is good data, there is good evidence that you can continue it for 3, 4 years easily. See,
So
earlier,
now the age, yes, sir. Yes,
what
sir.
is their age? What is their age?
Now the age is 8 years.
Ajay, only 8. No, you can still continue for 2 more years.
Okay.
And
So
those
when
who
we
are
stop at the age of 10 years or 11 years, if there is a
maybe.
rebound, again, we have to
We
start
will,
the.
yes, why not? If there is a rebound, you will have to start. I mean, not for rebound, but for the fact that, see, rebound will not be more than 0.5 diopters. So whatever rebound, so
Okay.
rebound, there are few theories whether rebound is actually because of axial growth, or rebound is because, whatever subnormal effect it had on the lens thickness came back. There
Correct,
are
correct.
there are 2 articles, and there is one more article which, which contradicts this, and they say that there is at least some subnormal effect on the lens thickness with atropine, and we know that higher the concentration of atropine, more is the rebound. So rebound is probably thought about that it could be because of that, but if it is because of that, it should not be more than 0.5 diopters. But
Okay.
if you gradually feel that rebound is even after rebound, there is some progression, you can always restart atropine. So even in ATOM studies or even in LAMP phase 4, they have talked about using it for 5 years, even after stopping after 3 years, and then seeing that there is a rebound. They started, either they started a higher concentration in LAMP or they restarted atropine 0.01% in ATOM 2. So you can always restart atropine.
So then there comes this pubertal age group where around at around 10 or 11 years they have started using their atropine. Now they after 2 years now they want to stop the atropine.
Why
So
they
is
want to
there
stop?
any pubertal growth
There will
effect
be
of the
growth.
pubertal growth?
Prepubertal growth will definitely affect their myopia progression. There is no doubt about it.
Okay, so we can continue atropine during this period to around another 2 to 3 years.
Yes, you can
Uh,
easily continue. And if needed, you can add myopia defocus glasses also, if there is some progression.
Okay,
So
okay.
there is a question on chat that no axial progression documented for 2 years. How do you taper LDA? So for me, what I do is I try to see what is the age, and only after 16 or 17 years I think about tapering low concentration atropine. So Janani, what is the age of this particular patient? For 2 years, you have no axial documentation, no axial progression documented.
16 years, sir.
Then you can tell the patient to start putting drops alternate days for almost a month, and then if the patient is 16 years, there is no axial elongation. The only thing we are afraid of is rebound.
Mhm.
So then we can tell them to put it alternatively for a month or two, and then twice a week for a month or two, and then just stop.
Okay, sir. Thank you, sir.
So different people do taper it differently. I think now what has happened is that we have a lot of patients on atropine 0.05% and atropine 0.01% twice a day. So what we do in tapering them is that we bring from 0.05% to 0.01% twice a day, and then gradually we tell them to put it once a day over a period of 2 months, and then gradually we tell them that now you can start putting it twice a week for a month or 1.5 months, and then you stop putting atropine.
Thank you, sir.
Sir, can you hear me?
Yes, go ahead.
Sir, do you start atropine or any myopia control glasses at the first visit if the patient
No.
has any risk factors?
No.
If he
No.
has risk factors for progression, then
What are the
also,
risk factors?
I mean, parental myopia and siblings have myopia. No. No.
Sibling myopia has been out of risk factor now. It is only parental myopia which is a huge risk factor. So parental
Okay.
myopia, yes, it is a risk factor. But
Mhm.
if did I talk about genetics in this chapter or last class? Okay, last class I talked about genetics. So basically the whole point is that the genes would make you susceptible towards myopia progression. Nevertheless, it is your near work and your real environmental work that you are doing. Like if you are sitting too much, if you are reading a lot, if you are not sitting in enough sunlight or open areas, it is then that your myopia will progress. So I think what we have to do is that we just have to wait for progression, because at the
Okay.
end of the day, regardless that that this patient will progress, is if the patient doesn't progress, you don't know what you have treated. I know it is quite tempting, but you have to document the progression because you are treating progression. In the absence of progression, you are not treating anything.
But I've seen, sir, I have few friends in US. They're even in pre-myopes, they are prescribing this low dose
No,
atropine.
pre-myopia. So I had published an article on pre-myopia in 2022. So not that
Mhm.
this is not something which has come up suddenly. Pre-myopia, you can treat pre-myopia. You should have documentation that these patients are losing out hyperopic reserve very quickly.
Okay.
All the patients that you have in pre-myopia, they should be losing out. Just now I saw a patient 1 hour back. Patient's elder sister has myopia. Mother, father don't have myopia, but elder sister has myopia. He was having plus 0.75, I think 2 years back. Then it became plus 0.5. And we obviously were not giving that. But because his elder sister had myopia, we just examined him and he had an astigmatism of 1.5. And then he lost it and became emetrope, like 0 with a cylinder of -1. And then
Okay.
today he was minus 0.5 with a cylinder of -1.
Right.
So only last time when he was 0, we told them that you are a pre-myope and your axial length also has been measured, and his axial length in right eye was 24.14 and today it was 24.44. So he was progressing very quickly in 6-8 months. So there is an documented evidence that this is progression. See, that is what you
Right.
are treating. Even in pre-myopes, see, some people
There
may say
should be
that,
an evidence,
yes, you
basically,
need
of
an evidence
progression.
for otherwise, how would you know what you have treated?
Right. Mhm.
Otherwise, it is very difficult for you to, yourself understand what is, what is working for the patient. See, it is like this. If you have a pressure of 18 or 21, or say you have a pressure of 20, 21, and you have, or I would say 23, and you have started timolol. Now the pressure is 21. You don't know whether patient was ocular hypertensive, he really had glaucoma or not. So,
Right.
IOP is the modifiable risk factor, but there has to be a progressive optic neuropathy to treat glaucoma.
Mhm.
So at this point of time, we are treating only myopic progression. We do not have very robust calculators to know that he will progress and he will not progress. Also, we have no clue whether what we have treated has actually worked or not. If in absence of progression, we don't know what is working for the patient. He may not have progressed even otherwise. That is what will come out at the end of the day.
Right.
So the axial length in children, you
Hmm.
prefer to, we have to use under general anesthesia only, because it is very difficult for the cooperation of child.
No,
For
you can't
axial
measure.
length.
If the child is less than 3 years, you just have to wait, sir. You can't measure. And taking the patient in for under general anesthesia for axial length, I don't know if the parents allow. That is fine. Otherwise, it is not something. See, even if the myopia progresses, so some of our colleagues who are not into pediatric ophthalmology or not really into myopia, what they say is that इतना सारा क्या झमेला है, कितना बढ़ जाएगा? मतलब, if you don't treat myopia, how much it will increase? Maybe 5 diopters. So if you don't treat it for a year, how much it will increase? Not more than 0.5 or 0.75. So
So
yes,
from which age you start measuring excellence without anesthesia, without general anesthesia?
sir, we try it out at 3.5 years and tell them that we want to measure. And then if they allow us to measure, we will measure. And if they don't allow us, we just write that, we tried to measure axial length, but they have not allowed us to measure it. And then we'll measure it next time.
But do you feel that child of 5 to 6 years cooperates enough for the actual
Uh,
measurement?
5 years, of course, he cooperates. 5 years, he will cooperate. In our clinic, he cooperates, sir. I don't know.
And most of the times I feel that when the patient comes for a revisit on third or fourth visit, and we always say that number has increased a little, patients, parents or attendants, they always get unsatisfied, stating that we had expected that you will not only control but reduce it. And
Yes.
number one. Number two, as you are mentioning a case who had a plus power in the beginning, became emetropic and then myopic, then it is again controversing what the statements which we promised to the patient.
No,
तो
no,
पहले तो
we
ठीक हो
never
गया था, अब
promised.
नंबर फिर आ गया.
नहीं नहीं, हमने प्रॉमिस ही नहीं किया सर. हमने तो उनको यही कहा ये प्लस का नंबर है, थोड़े दिनों में 0 होगा, फिर माइनस होगा. तो नजदीक का काम बंद कर दो और टीवी मोबाइल कम कर दो. सो दिस इज व्हाट वी टेल देम ऑन द फर्स्ट इंस्टेंस इटसेल्फ, दैट दिस इज योर पावर, this is in plus. It may go towards 0 and become minus. It may not go. So that is the first moment I sit with the patient, I tell the patient that this is your power. It may progress, it may not progress. If it progresses, we have treatment. If it doesn't progress, we will sit quietly till it progresses. And we also tell them that it will not progress if you do these things. So if they follow that, it is fine. Otherwise, we tell them, see, you are not following this. and so your power has progressed.
The patient's attendant always say that you have not controlled the myopia, which you can claim that you are controlling the myopia.
Then what else we are doing? We are controlling the myopia only.
We are controlling the progression, not controlling the myopia.
Oh, acha, talk of words. No,
Yeah.
we tell them at the first instance कि boss number आपका कम नहीं होगा. This is a one-way traffic. Number आपका कम नहीं होगा. This is the baseline. The first line is you have got glasses. It is not going to reduce. And we always will say that your myopia progression will be controlled. We never say that we will control your myopia. You don't have to say that you have to control you cannot control myopia. It is impossible. That is what I said when I started the lecture, that it is purely about progression. If there is no progression, we are not doing anything to that patient. That patient is not for any myopia strategy. Everything just for for the fact that you don't have to keep on saying myopia progression. You use a easier word by saying that you are controlling myopia. You are not. Nobody is about myopia control. It is purely about myopia progression control. It is not at all about controlling the myopia.
जैसे अब दवाई एक आ गई है प्रेस व्यू पेलोकार्पिन
जी
लेस
जी
परसेंटेज
जी
फॉर प्रेस बायोपिया.
जी जी जी.
वो कहते हैं वो दवाई तो हमारे लिए तो हो गई है कि बच्चों के लिए आपने ऐसी कोई दवाई नहीं बनाई है कि नंबर. Why can't you use pilocarpine to constrict the pupil? Because with constricted pupil, patient can see better.
No, sir. He can see better, but that may further, he may accommodate more, and that may further elongate the globe. We don't want that. It is, it is contradictory to whatever is available in the market, whatever we have talked about.
Because a child prefers to see with the eyes squeezed a little, because myopic people can see with the smaller pupil better compared to the dilated pupil.
So we should use pilocarpine.
No, because patient asked, why can't he use the same medicine? Because it was a doctor who was
Can't
asking the
use
question.
that's sir. They cannot argue on scientific things with us. We can't use means we can't use. I mean, this is not about their Google knowledge and our scientific knowledge. We know that we cannot use it. They can ask for anything. They can ask that why can't I use a contact lens instead of intraocular lens? They are free to ask anything because they are lay people. उनको क्या फर्क पड़ता है? They can ask anything.
No, sir, I am asking you,
हाँ,
like
please.
pilocarpine in low dosage is controlling the presbyopia.
It is not controlling, sir. It is just
No,
making
so
sure
it
that
is
pupil is constricted and it is causing the accommodation. It is increasing the accommodation. It is causing the contraction of ciliary body. We want to
right, sir.
relax ciliary body.
Right, sir. That presbyopia is little relieved for some time.
Yes, of course.
Similarly, if we use pilocarpine to constrict the pupil, because we know that with a constricted pupil, myopes can see better.
Yes. So,
Why don't we use that pilocarpine for myopic patients?
because we are not into treating myopia, we are treating into myopia progression. We are not giving them a solution for glasses. You are giving them pilocarpine as a solution to small myopic glasses. We are not into treating myopia, we are treating into myopia progression. Pilocarpine will never stop myopia progression.
नहीं सर, we are adding the two things. मान लीजिए उसको -3.5 नंबर से जो दिख रहा है, अगर हम उसको माइनस से विद पिलोकार्पिन करेंगे तो he'll be able to see better with a lesser power.
Sir, that too, even we can do LASIK also. We can do LASIK at 6 years of age. He will see better with that.
No, sir, by using pilocarpine and the spectral number is decreased a little.
I understand.
So we can say that number has not increased. It has decreased a little.
Sir, why will we say that? I mean, see, if the number has increased, it has increased axially. We are playing with
Right,
their
sir.
accommodation to make sure that they see clearly. Why would we do that? Because in the longer run, this induced accommodation not only can create headache, it can create iris cyst, it can create retinal detachment. There are ample case reports for that. That is just the side effects of pilocarpine. Second thing is, it is not going to affect myopia progression in any way. आज वो 4.5 पहन रहा है, पाइलोकार्पिन डालने से हो सकता है 3.5 हो जाए, बट 6 महीने के बाद वो 4.5 का 5.5 हो जाएगा.
So again, the progression, we can claim that progression has reduced a little. Because
Why would you claim something which is not there, sir? It is not
I'm
our
just,
problem.
I'm
It
just
is their
imagining
problem.
that those who just try to fight with us, stating that we are not capable of doing this.
सर छोड़ दीजिए ना उनको क्यों let them be happy, let them be very happy about I always refer them. I tell them that you can. I have learned from Arvind Eye Hospital Madurai. I have worked with good guys in South, and I have worked at RP Center. I have worked with Dr. Sharma sir. Why don't you go and take a opinion of Dr. Sharma? And now Rohit is there. Why don't you go and talk with Dr. Rohit Saxena? Or why don't you go to Dr. Shashikant Shetty or Dr. Sumita Agarkar? Because these people are the leading people in the country. That is how I exit from that. If they come to me very aggressively, I just tell them that, you can always take a second opinion. And I give them the address also. Why not go there? There are a lot of times they actually go there, they come back saying that Dr. साहब ने तो कहा है कि आपको ही दिखाना है. So I think that is fair. And I think there's one more question. Apart from parents, if sibling had moderate myopia, both eyes, no history of high myopia in two generation, so is there chance? See, any family history of myopia, if there is sibling myopia, if there is family history of myopia, if there is two generation who has myopia, everything depends on what they do. So the genetic predisposition is definitely there. But most important is that apart from genetic predisposition, what are they doing currently? If they are doing a lot of near work, if they are sitting indoors, if they are waking up at night, breaking the circadian rhythm, or if they are reading in dim lights, these are all risk factors which, if the patient is already having genetic predisposition, on the top of it, if they are doing all this, they have these risk factors, there's a good chance that they would go into myopia. I think one of the ways of increasing your myopia practice is to tell the siblings and check those siblings. Always check the siblings, telling that you can detect myopia slightly early. So that is one way of doing it. There's a question by Dr. Ankita that is there any role of LD in preventing pre-myop getting converted to myop? We did this work 3 years back, published in IGO. Yes, you can use low concentration atropine in preventing a pre-myop, but the term used is not preventing pre-myop. The term, so whatever you are saying is correct, but the term that they use is that they delay the onset of myopia in pre-myop. So whatever you said is same as I did, except that I used a different word of saying that it is to delay the pre-myop from being converted to a myop. Does that answer your question, Dr. Ankita?
So actually, yeah, that answers the question. But I just want to know, since you said that pre-myops only if they are progressing to
Yes.
myopia,
Yeah, because
so only
if they're not progressing, then there is very low risk that they will get converted to myop.
okay. Okay. So then if even in the first or maybe second instance, if we see that they are progressing only, then the role of my like
Yes.
LDA comes.
Yes.
All right.
Yes.
So, but there's a definitive role that it can delay the onset of myopia.
Yes. Yes.
All right.
Definite role. And it is not
Okay.
just our work. There are two more articles across the globe. We are the only people from the country, but there is more evidence across the world that atropine does help in delaying the onset of myopia and pre-myopes who are losing out their hyperopic reserve.
Okay, sir. Thank you.
There is a question by Janni. Yes, 6-year-old, right eye -6, left eye -4, defective vision 2 years. First checkup, father is a myop, high myop. Ideally, we give single vision glass now, call for follow-up 4 months and progression, start treatment only if. Yes, because and you should always take axial and Janni, because if there is no axial elongation, see, you have to be solid into it that there is a progression. Because otherwise, it is very difficult to tell the patient, as Dr. Jaswant was talking about, it is very difficult to tell the patient what are we doing and what difference it has made. Otherwise, he would say that, okay, you have started these drops. Is the drops which is working? Or even otherwise, he would not have progress. So if there is a evidence that there is a progression, you are treating that progression. And you can directly tell the patient that it is -6, -5. This is the baseline. This is not going to go down. If you think that I will be with my drops or with myopia control glasses, the glass power will reduce from -6 to -5. that is something which we are not into. So we cannot promise that the glass power will reduce. We can only promise that their progression will slow down, if at all there is a progression.
Yes, sir. Okay, sir.
Wonderful.
So,
Yeah.
what is your first line of management? If there's a progression, do you prescribe LDA along with glasses or just LDA first?
I mean, there will be lectures on that, but on the face of it, if the patient is progressing very fast, nowadays I start atropine twice a day. If the patient is progressing, very fast and is affording, I may start low concentration atropine once a day with glasses. So that all depends on how much, so the treatment depends purely on financial this thing, mainly because, even if I tell them to use myopia defocus glasses, if they don't have money, they will not buy it. So there is no point. So we normally would sit with the patient, talk with the patient, what is to be done. This is your myopia progression. If you're not going to do a combination therapy, which we feel you should do, then we will go on a higher concentration, like we will start atropine 0.01% twice a day. In 1 or 2 patients we have started with atropine 0.05% also. So that is very, very crucial. What you are doing is that you are trying to see how quickly he is progressing, and you are trying to blunt that out. So if you want to start with a low concentration atropine once a day, and if progression is more than 0.75 diopters in 6 months, then you have to understand that he has to use another modality also. And all these modalities has been proved that if you use a combination therapy, the control is much faster, the control is much stronger, and if you use a higher concentration of atropine, your control is more better. So if patient is ready to use 2 things, you can do that. If not, then start using atropine 0.01% twice a day. And now I think atropine 0.05% will be available, but we have been using it since almost 4 years. So 0.05% works much better than 0.01%.
Okay. Okay.
Okay. So if there are no questions, we can finish the meeting. Dr. Aval, you will have to end the meeting because I'm not the host. So it was good. I think we will put the next video on Monday for atropine as a drug for myopia control. And then we will have a meeting following that. What I will also suggest is that if you can post the questions on the group, we can straight away, take it up in the live meeting. Even otherwise, we can, if you are just ready with the questions, we can just take it up.
Will
Thank
we
you.
have the video recording of this meeting?
Yes, it is being recorded.
Or will we see it there? Will it be presented there in the group?
Yes, it will be there.
Okay.